Okay, so we had some really good discussion in our group this morning, and I think the first thing to highlight was that there was still some uncertainty as to what the message is that we want to communicate, and I think that came out this afternoon as well. So that was sort of our first sort of need, is to really clarify what it is that we are communicating about the project. I think we felt very importantly that when we do decide what it is that we're communicating, the timing of when we communicate is also equally important. Thinking about the broader stratified medicine world, making sure that we're linking in our messages with when there's calls and that sort of thing. The case studies, I think we all agreed were really useful, and we'd heard some really good case study examples in the morning. I think what I took from the discussion was that some of those case studies don't need to be specialty specific, that hearing them can prompt, you know, the thought process for other specialties about how that might translate into that particular specialty. However, there might still be a need for some specific specialty case studies that are absolutely tailored to that particular disease setting. I think what we felt was there was some absolutely essential for some clear mechanisms for cascading the messages, particularly, you know, between the champion and the local LCRNs and the facilitators, but really to define what the roles and responsibilities are of those people and the other stakeholders involved. And then we talked about the need we mentioned in the morning about there being this stratified medicine community, but actually, who is that, and will it differ from one specialty to another? So really thinking about identifying who our key partners are, who our stakeholders are, and really mapping that out. So I think they were the key points. Anyone else on the table feel like I've missed anything crucial?
Any comments from anybody else?
I found it quite challenging, actually, leading this session this morning. I felt like, and I'm going to be one of the facilitators, and I felt that I hadn't really grasped what it is that this piece of work was all about, and so I felt that in itself was a bit of a need to sort of further my own communication about what this project and my role in it would be.
So is your communication strategy going to be national or local? Where's going to be the focus?
I think it's needed both.
So our remit was to look at workforce development, how we can give our NHS workforce the resources to be able to deliver the stratified medicine programme. Here are 5 points. So a MOOC, a massive open online course. So any research delivery staff who are involved in delivering stratified medicine trials might be required to undertake the training via a MOOC, a little bit like GCP. You're registered to be able to do those sorts of studies. These already developed bite-sized learning materials, well, none of us in our group knew about them, so we appreciate they've just been put together, but obviously promoting those beyond the CRN. And again, the LCRN delivery facilitators, these 15 around the country, will be key to promoting this resource. And of course, we need to identify which studies are StratMed. And when we go out, I suppose, in our LCRNs, you know, one of the conversations we'll be having is with clinicians who perhaps aren't involved in research, NHS CEOs. So we want to be sure that we're talking a lot about the benefits to health of StratMed rather than how complex and how difficult these are to deliver and resource intensive. So it's about getting the balance right. And you know, we may need, I like the previous speaker is probably going to be a facilitator and IPAT. So you know, I may also need some training on, so I understand what the benefits are to health care of these studies. And then we'll need, you know, it would be good to have some annual high-profile meetings to feed back on developments across the patch. So we learned from our group that there's regular CRN leadership summits. Perhaps these are twice a year, I think, and maybe we can have a regular slot, maybe one of those a year to feed back on how things are progressing. And then, you know, metrics. It's always good to have an idea of, or to know that we're being measured on what we're doing, and so that we can monitor our progress. And it's always nice to have, well, personally, I always like to have a goal. Where do we want to see ourselves in a year or something? So something like that would be useful, I think.
Okay, anybody else from the group, anything else to add?
So our conversation was mostly around how facilitators and champions can help support the delivery of stratified medicine studies. And one of the opening questions that we had was, what makes a stratified medicine study different from any other complex study? And rather than creating a silo for the delivery of stratified medicine studies, how do we equally prioritize the delivery of that portfolio alongside the rest of the NIHR CRN portfolio? So one of the things that we thought of would be helpful was to demystify stratified medicine studies. What are they? Bearing in mind the multiple definitions of them, but also perhaps having an armory of good and bad examples of stratified medicine studies which have successfully or unsuccessfully delivered to time and target, and the reason behind that. The other thing that we thought would be helpful on a more operational level was the development of a tool for stratified medicine study delivery. So leveraging the expertise and knowledge of the champions, of the facilitators, but the wider research delivery management community. What makes stratified medicine studies different to deliver? Any hints, tips, but also managing expectations around them, and particularly for newer members of staff who are taking on or participating in stratified medicine studies, what are the things that they need to be aware of when taking them on? The third element, which we thought was crucial, was alignment of R&D departments and not only LCRNs, but the CRN as a whole. So for the purposes of setting up and delivering a stratified medicine study, we found that these studies can often be challenging to set up, and that's usually because of the perceived barriers that our research team has in mind. And depending on who that team goes to, whether it's an R&D department or the LCRN, perhaps a slightly different answer is given around if these barriers actually exist or not. So we thought that it's quite important that both groups of individuals work together to be giving the same message around the support available for delivering stratified medicine studies. The next item was around signposting of CRN stratified medicine studies and the incorporation of the research design service and NOCRI. So within the NIHR, we already have parts of it that have positioned themselves in early phase medicine. So we need to be leveraging their function and their support to make sure that studies are coming through onto the portfolio, and where those studies come on, that there's adequate support available. And equally for partners like NOCRI to realize that within the CRN, actually, we have a very established stratified medicine environment. We have a community of individuals who have all the necessary skills and expertise, not only to develop that study, but also to deliver it. And in the context of the research design service, we thought that part of the study support service is around early contact and engagement, and actually it could be too late for that study. It's already quite advanced in its development, and there isn't really an opportunity for a champion to input into that study and make it deliverable in the NHS. So actually, by having the involvement of the RDS in conjunction with a champion, we have more of an opportunity to shape studies that can actually be delivered within the NHS. And then the last element was around it was multiple areas trying to be merged into one fifth bullet point. So the first is around diagnostic services, but not limited to that. And this, we thought that one of the differences between stratified medicine studies and another type of study is the amount of support that's needed from support departments, pharmacy, radiology, pathology, and actually how is that cost factored into those studies, and how is that support, reliably called on for the delivery of those studies. Screening burden, which we've touched on quite a lot this morning, but also the last point was around computational resources. So everyone that takes on a stratified medicine study immediately builds a database or looks to a database to start looking for potential patients. And actually, you have pockets of readily available information around patients. And if there is a way that that can be pooled together so that when studies land onto the portfolio or they're being conceived, there is a centrally available resource to know what kind of patient population you're looking for, that could be quite beneficial. I guess, and to be completely radical and introduce the sixth point, one thing that we didn't perhaps touch on was on when it comes to the actual delivery of the studies and needing support and escalating those studies, how we go about doing that, particularly as we have national specialty leads in post, who we often draw the support of. but how is the stratified medicine community also incorporated in those discussions?
Within our group, we had some people who are facilitators and who are champions, and so there seemed to be kind of a hunger to really know what those roles are, so that on the shop floor, kind of operationally, we are going forward with something concrete in terms of what we can actually do. So around the stratified medicine facilitators, looking at this kind of, again, operationally, they felt that their role was kind of around study intelligence, trying to support new CIs who may be approaching the RDS around stratified medicine studies, sharing good practice across different CRNs to, again, sort of strengthen and support where stratified medicine studies may be applicable. And then the stratified medicine champions were kind of more a clinical interface. So this sounds a little bit vague in terms of engaging with clinical teams and patients, and that's where we wanted to drill down and say, well, actually, what does that mean? When we say engagement with the NHS, it's a very loosely used term. What does that actually mean in terms of what do we go and do as champions? So we talked about case study toolkits, and I think people have mentioned this before, but it's something that you can use to hand. It engages the audience. You see direct patient benefits. You have a patient on a video, or you have numbers recruited to a study where it's had an impact on clinical care. They're always things that echo long-lasting when you walk away from a group that's not necessarily represented like we are here, where you've got a group of dedicated people. The people that you're interacting with, stratified medicine is not necessarily high up on their agenda at that point. Making the most of other opportunities like digital platforms. We've talked about local versus a national strategy. So yes, we all need to have a local strategy because that may differ in terms of specialty specific, site specific. But then nationally as well, the responsibilities of the coordinating centre, national initiatives by the government, other high-profile studies. I'm just putting here the 100,000 Genomes Project, something through NHS Choices, again, which targets a wide audience. So we came up with these kind of areas that we can focus on, but the group still had questions, which I think is good at the end of the discussion, around kind of, do we need a broader specific strategy that actually, again, specifically says, what are we communicating? So generally, what are we communicating through these links? Because otherwise we go away from the meeting and we say, yes, you need to go and engage with your local clinical team, or you need to go away and engage with your local CRN, but what do you need to engage? What is it that you actually need to talk about? What are the tick boxes that you need to think, I need to have done these, and where is it made an impact? And then to do this meaningfully, it was raised, do we need more resource and time? At the moment, we've got a community which is hung on a couple of sort of champion type roles, but do we need to, again, detail that a little bit more? So what's the actual time and resource that's going into that specifically? So we wanted to really kind of, at the end of this, walk away with something where we could say, when I leave this room today, I'm going to go away and do this, as opposed to I'm going to read something on the internet or chat generally to my colleague. So yeah, that's it.
One of the key things which cropped up was we felt in the post-Brexit world, stratified medicine is a very important opportunity for UK to play a bigger role. There may be other losses elsewhere, but this is certainly something which we excel at. So this is certainly an opportunity to look forward to, and that's something which the powers to be can impress on the powers to be within NHS, NIHR, and so on. And we also found within our table, the champions didn't know who the facilitators were, the facilitators didn't know who the champions were, and most of us didn't know what a champion stood for or what a facilitator stood for. So we all rapidly learned, and if that is the case within a group which is motivated and committed to spend a day in London on stratified medicine, one can only imagine what the impact of this knowledge or absence of in the wider community is. So the first step is to highlight to the wider research community who stratified medicine champions are, the fact that there's 29 of them, mostly representing specialities nationally, and then the facilitators who represent each LCRN. So that dissemination needs to happen. We need to disseminate what stratified medicine stands for in a very simple way, perhaps using videos which are universally resourced, with good examples like what Chris Griffiths gave this morning, which is contextualizing what psoriasis. So these are all important leadership points for the champions, but the resources can be universal. Whatever is developed centrally can be delivered locally. And then we certainly delved a lot into the training. So we had a call through NIHR for a precision medicine ACF not so long ago, which certainly two members in our table were aware of. I don't know if the wider folks are aware of. There was a precision medicine call within the academic clinical fellow program, which is a welcome development, but we felt it shouldn't restrict exclusively to medics. So we need to take this into the arena of allied health professionals, pharmacists, where there seems to be a desperate lack of pharmacist engagement in leading trials, apparently. And also, we wanted the LCRNs merging closely with the Genomics England 7 hubs, because there's a lot of resources there. And so where possible, the facilitators, the champions, work with the Genomics England hubs because they have the resources already available. And similar training opportunities for nursing folks as well. And having, if stratified medicine is a concept that's difficult for us to understand, if the glossary has 7 definitions, then imagine how we're going to communicate this to our patient population when they participate. So I think we need to work, part of the leadership role is to ensure that we can communicate what stratified medicine means more effectively to our patient populations. I think that was it, and then there was convergence on all of the issues that were discussed before, so I'm going to avoid repeating them.
Well, we will be very quick because we actually covered an awful lot of the stuff that's already been done. The tools section, what leverage do we have as champions and as facilitators to support stratified medicine? That was a really good discussion. I think we talked all about engagement with trusts, or in my case with CCGs and primary care. How do they work together? We had a long discussion about the job description. Eventually somebody found one on their phone for the facilitators, the SMFs. So I suppose there's a little bit of, we need a bit more definition, clarification about what the role entails for both champions and facilitators and how they might actually interact with each other. There was a proposal we should all get together and so in terms of a community. I know it says virtual community, but I think just getting physically in the same room at some stage, getting a feel for what each other can do and sharing the knowledge like I've just been sharing about primary care. We had a very interesting discussion, I think, about what would define a good champion or a good facilitator. That was a bit about metrics. We struggle to find metrics, but we're looking at sort of process, how you engage with local PIs, local CIs, setting up studies, perhaps helping to recruit, showing benefit across recruitment in stratified medicine studies was good. And identifying, as Mani was just saying, in your annual review, what have you done which is good? And that came up. And also recognition of the role at both ends. So that's exactly what we've just been talking about. We talked quite a bit about strategy, that perhaps there needs a sort of, I don't know whether there's a common strategy, although we've got the NIHR strategy, we've got the stratified medicine paper that we've got, and perhaps just buy-in is needed to a national strategy, both NIHR but the CRM, but also then I think we talk about some bottom-up input into that strategy. So that was perhaps something which we hadn't discussed before. Also engaging of patients, that we haven't mentioned that really. We felt that was critical. Innovative ways, getting usual sort of thing, getting PPIE in really early, promoting, perhaps using the experience of cancer studies where there's good patient engagement about the nuances of stratified medicine, perhaps getting those patients in early, particularly they're very skilled patients around, getting some videos and really trying to encourage, and that could be part of the resources that the champions and the facilitators have locally. And lastly, we talked about other key stakeholders, but industry. We had a discussion a bit which has already been discussed, how important it is to say we're open for business and we're going to deliver, and this is the way forward. I don't know if that's helpful. A quick.
Thank you.